So hello and welcome. My name is Nisra Parna. I am the manager for Patient Engagement and Public Advisory Roundtable, or PAR, at American Thoracic Society, or ATS. We use a lot of abbreviation here. So today's webinar is on addressing challenging infection. This is brought to you as a part of the Lung Disease Week at the ATS program. This lung disease program is held at a weekly intervals throughout the year and is designed to foster information exchange between patients, advocates, scientific, and clinical experts. We have a number of events throughout this year, and such as understanding PFT, recognizing medical trauma, advocating for child lung disease, and nutrition in lung health, to name a few. This is our first webinar of the year, so this is very exciting to get this ball started and with two amazing people. So please check back our website for new lung disease webinar sessions and patient information. I have dropped down the website for us. I linked it here, so this is the updated, and everything is live for this session. So please go ahead and check it out. And I've also shared the YouTube channel for ATS. This webinar will be live and uploaded in our YouTube channel in a day or two after today. This webinar today will be a roundtable discussion, and it's intended to be interactive. The information presented here today is for educational purposes only, and it's not intended as a substitute for direct medical care for your provider. Please contact your primary care provider or specialist if you have any questions related to your specific diagnostics and treatment. I would like to introduce Michele Manion, the founder and executive director of Primary Ciliary Dyskinesia, and she is the immediate chair of ATS PAR. And Siri, can you pronounce your last name for me, please? So sorry.
Vaeth.
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 Vaeth. Okay. Wow. I've known you for a year and I've never asked your last name. I'm so sorry. So Siri, Vaeth. Well, Siri,
Vaeth with a V.
Vaeth. Okay. Vaeth. Executive Director of Cystic Fibrosis Research Institute, Chair-elect of ATS PAR. So let's start with Michele.
Thank you, Nusrat. I have known Dr. Lee for 2 decades, but even I don't know all of the things she's done. So I have to have a little cheat sheet here to introduce her. Dr. Margaret Lee, who goes by McGee, recently retired from UNC Chapel Hill, Department of Pediatrics and the Pulmonary Division, where she had been for over 40 years. Throughout that tenure, she provided care for children with chronic lung diseases, taught medical students and residents, helped with fellows, many of whom I've known now through our interaction. And she engaged in research on chronic lung diseases, specifically cystic fibrosis and primary ciliary dyskinesia. She also was given many awards, including the Teaching Award from the Pediatric Residents and the UNC Department of Pediatrics Faculty Mentor Award, as well as an American Thoracic Society Pediatric Assembly Lifetime Contribution to Pediatric Respiratory Medicine Award. Additionally, she has written almost 30 book chapters and has published over 125 refereed research articles. But more importantly, she continues to help train the future leaders in pediatric pulmonary medicine, something for which we are very grateful. And her commitment to patients can be seen from the fact that after retirement, she took on a leadership position with the board of the Primary Ciliary Dyskinesia Foundation, for which we are very grateful. So Dr. Lee?
Yes, hi. So I don't know that I have anything else to add. Thank you very much, Michele.
Awesome. Nice to meet you. We will just move forward to Siri introducing her expert.
Hi, it is my honor. And hello, everybody who's here. Thank you for being here. In addition to being the director of the Cystic Fibrosis Research Institute, I'm also the mother of a 29-year-old who lives with cystic fibrosis. So it's been a almost 3-decade journey with this disease. And along the way, I have met some extraordinary people, extraordinary researchers and clinicians, and really one of the high water marks in this realm is Dr. Luke Hoffman. Dr. Hoffman is a clinician scientist. He's both an MD and PhD. He's attending physician at Seattle Children's Hospital and associate professor in the Department of Pediatrics at the University of Washington School of Medicine. Dr. Hoffman is the director of the Seattle Children's Hospital Therapeutics Development Center for CF Microbiology, where he also directs a CF clinical microbiology lab. Dr. Hoffman's research focuses on chronic lung infections, particularly in patients with cystic fibrosis. He too, another incredible scholar and researcher. I think when last time I looked, like over 175 publications. Luke, you're busy. He serves as a mentor, as does Dr. Lee, to so many people, medical students, fellows, and he is beloved by his patients and their families, thanks to, of course, his excellent clinical care, but also his consistent and caring patient focus. He's very generous with his time, the patient community, and the organizations that serve them. So thank you for being here, Dr. Hoffman.
Well, thank you all of you for joining us today and doing the first webinar for the year. I would like to tell the audience that we have the Q&A section. Please feel free to go ahead and take advantage of that button. Ask us any questions that you have throughout the session. And we will try our best to answer those questions as much as possible. So I would like to set up an icebreaker questions for the experts. For today's, our topic is about addressing challenging infection. In your experience, what are some effective ways to educate patients and caregivers about infection prevention and management? Whoever would like to go first.
Go ahead, Luke.
Sure. Oh, just that. First of all, I want to say thank you very much for inviting me today. It's a ridiculous honor. And that introduction, Siri, I had to mute myself because I was laughing as you introduced me. You made me sound so cool. But anyway, I'll take it. I appreciate it. Infection prevention and infection control. These are complicated concepts when it comes to these lung diseases, because the way that these lung infections in people with these diseases happen is that everybody is constantly inhaling. All of us are constantly inhaling tens of thousands of liters of air a day, and all of the stuff that's contained in that air deposits in our airways. And most of us can clear those particles, whatever is suspended in that air, out through a number of mechanisms that we have in our bodies. We have mucus that collects it, serves as a vehicle for our airways to move things out through coughing, and then we have these nifty cilia, which are, of course, dysfunctional in people with PCD as well as people with CF. And so the way that people get infected is basically by breathing. And in a lot of cases, the bugs that we're talking about, the bugs that cause these infections, are either already common among all people, they live in our airways, or in some cases, they're environmental organisms that are almost impossible to avoid. There are some exceptions to that. There are some highly antibiotic resistant versions of these common bugs that we like to prevent people from transmitting. There are some environmental organisms that, even though you can see them in the environment, they're not easy to get. And when somebody becomes infected with them, we think they have a very high burden, and then they can transmit them to other people. So in those cases where people are infected with really troublesome bacteria, or at least their cultures are positive with them, we like to prevent them coming into contact with other people with the same diseases. But preventing infection is a really hard concept, because really the best way to prevent infection is to try to minimize the effects of the disease itself. Both of these diseases involve impairment of clearance of all the stuff we inhale. Another way that I could take that question is by asking, how do we prevent people from having very antibiotic resistant infections? And as far as we know from the epidemiology, the best ways, two ways to do that is to avoid using antibiotics unless we absolutely need them. And unfortunately, sometimes we do. Antibiotics are remarkably effective at helping people recover from symptoms. But we don't, only in a few exceptions do we give people antibiotics just because they have the infection. Most of the time, we only use antibiotics when we feel people are sick enough to need them. And we try to limit that until people really need them. and they can be very, very useful, and they've definitely improved the lives and lengthened the lives of plenty of people. So that's one way, is to avoid using antibiotics unless we need to, and that's called stewardship. The other way, again, as I mentioned, is to try to prevent people who have very antibiotic-resistant infections from physically coming into contact with other people. And we learned during the pandemic just how effective some measures are, such as masking, which we were already using in a lot of cases, hand washing, and careful, assiduous cleaning of the area. I'm sure that I forgot something. I hope I answered your question, but Miggy, you've been in this field for a long time. I'm sure you've got something to add, or maybe you don't.
Yeah, well, I agree completely with everything you said, and I'll summarize with number one is you still have to be attentive to airway clearance. You got to get the mucus out. That helps prevent infections. You talked about antimicrobial stewardship, or being careful about use of antibiotics. Just don't willy-nilly treat every runny nose with an antibiotic, or you're going to promote resistant organisms. And careful attention to hygiene, hand washing, and those sorts of things. A couple of others that I would add is many of our patients use different devices to inhale therapies, and you just have to be careful to make sure those are cleaned and air dried so that you're not getting bacteria in those devices that you then are inhaling. And then the last thing I might add is vaccines. I am a firm believer of viral infections causing an exacerbation, that then bacteria come in later. So I would encourage use of vaccines like influenza vaccine, the COVID vaccine. Pneumococcal vaccine may be more important in PCD than in CF. We get more strep pneumonia infections. And then you might think about RSV in infants. That's kind of up in the air whether it's needed, but certainly any infant on oxygen, I might use the RSV vaccine.
All right. Awesome. Thank you so much for answering the question. So we will get into our questions for the webinar. So first one is by Siri.
Start from the bottom. What are the primary pathogens that are cultured by individuals with CF and PCD? Let's see. Why don't you go first, Dr. Lee, and then we'll move it to Dr. Hoffman.
I think they're pretty similar in childhood. The ones that we think of most commonly in young children with both CF and PCD are Staph aureus, Haemophilus influenza, in Moraxella, and then in PCD, we see strep pneumoniae would be in that same top tier. And then in early childhood, Pseudomonas is relatively rare in both diseases, and then becomes more prevalent as the patients are older. I think in CF, you may see by age 18, it might be as high as 40% of the organisms. And in PCD, it's less. It's probably about 10 to 12% patients have Pseudomonas. So, but those are the main ones that we think about. And then I'm sure you're going to ask about all the strange and unusual ones. Did I forget anything, Lucas?
You can throw in some strange and less common ones too, Dr. Hoffman.
Oh yeah, I know a lot about the strange and unusual ones, but they're not worth stressing. I think this is a really, I mean, obviously McGee, who's published on this quite a bit, she kind of wrote the book on what's cultured from people with PCD, and even comparisons with CF. Of course, you addressed it well, very well. I'd add a couple of details that we're learning, because people are still sort of understanding PCD as we're still understanding the disease and just how variable it is. There is, when you're talking about the individual bugs, there used to be a concept that PCD and other diseases like it just have the same microbiology in general as CF, but it just happens later. And it's looking like it's not quite like that. Even in children, for example, most children with CF have cultures positive with Staphylococcus aureus, and it's actually a lot less common in PCD. You see a lot more Haemophilus and Streptococcus than you see staph. You do see it, but it's less common. And it's almost, it's more than 70% of kids with CF. So clearly different. It's not as if there's a delay in getting staph. You just don't see it as often. And people do get Pseudomonas in PCD with modulators, and lately with an antibiotic use, we're seeing less of it in people with CF. But there's, and you didn't ask this question, I just think it's interesting, there's clearly a relationship between detecting Pseudomonas, for example, in CF and having more symptoms, having worse lung function. That relationship isn't as clear in PCD. It doesn't seem to be even there, let alone strong. And it raises a lot of questions. Why do people with CF tend to have different bugs? It's possible that they have that it's their mucus, the way their mucus is made. It's stickier. It has different chemical constituencies. Who knows? And why don't you see those same bugs in people with PCD and other diseases like it, like chronic bronchiectasis? But most equally important, I think when you look at the two diseases next to each other, we realize there isn't one bug that we can call the pathogen or the scariest pathogen, the one that we need to really worry about. There are just relationships in each individual disease that are teaching us a lot about what these bugs mean in the context of these illnesses and their disease severity. So I kind of went beyond your question, Siri. There are plenty of other weird bugs. There are some that worry us, like non-tuberculous mycobacteria, which is a mouthful. There are some Burkholderias that are also a mouthful. And those are much, much, much more common in CF than in PCD. The microbiology in PCD tends to be relatively simple and involve the species that Dr. Lee just mentioned.
In childhood. We don't know in adulthood.
Oh, right. Yes, exactly.
That's all in childhood. There are adults listening in, Luke.
I forgot
Yeah,
about
that's a perfect segue to the next question.
Yes, it is.
Do we see a difference in what's cultured in children and adults? And I want to frame this from a talk we just heard at our meeting from Ken Olivier, who is a bronchiectasis NTM specialist and who has been kind of trying to get the word out there that by adulthood, the lung, what you see in terms of microbiology in PCD starts to look a lot more like cystic fibrosis in adults than it does in children. Do you want to start with that one, McGee, just since we just had the meeting?
Okay. Well, I think you get into the organisms that we dread seeing in pediatrics, and they then become more prevalent in adulthood. But things like the non-tuberculous mycobacteria, Burkholderia, Cepacia, then there are things like, I don't know, Acinetobacter and some of the other gram-negative organisms that can be multi-drug resistant and challenging to treat. So, and we haven't even gotten, I mean, there's a whole long list of gram-negatives that, you just need a dictionary to look them all up, like Ralstonia and Pandoria and Achromobacter. I mean, the list is very long, as Luke knows well and studies many of these organisms. And that's what you see more in adults, but go ahead, Luke.
Yeah, I did not see the presentation by Dr. Olivier, but I've heard him speak about the relationship between non-tuberculous mycobacteria and other kinds of chronic airways infections. And yes, the prevalence tends to rise with age. The relationship with lung disease tends to get firmer as you get older as well, because plenty of people can have cultures positive, just like for the other bugs. We can detect these organisms. And one, it doesn't necessarily mean it's going to be there the next time we look. So persistence is not a given. And number two, even when people have persistent infection, it doesn't always seem to lead to disease, worse symptoms, faster lung function decline, destruction of the airways called bronchiectasis. We don't necessarily see that. And so we sort of have to divide out detection of the organism and then disease due to the organism to decide who needs to be treated. Because for some of these bugs, the antibiotics that we use are actually they're not pleasant. Sometimes we have to use multiple ones. They have organ toxicities. So we take this very seriously and we do this very cautiously. But yes, there are other illnesses. Asthma, for example, is in chronic obstructive pulmonary disease. These are illnesses where people have chronically inflamed airways and they also tend to have a higher risk of getting these non-tuberculous mycobacterial infections and disease due to them. And the risk seems to be particularly high at earlier ages in CF and then in later ages with PCD, which sort of follows that theme.
Excellent. Thank you so much for answering those questions. For the new
Can I ask a quick follow-up question, Nuth?
Yeah, of course. Go ahead.
I think this is an important concept for patients, and I am really glad that it came up. The idea that culturing an organism and being infected with an organism are not the same thing, and that might be why sometimes the decision is made not to treat. I think that is not always clear to patients. Can you expound on that a little bit? At what point do you consider it an infection versus just something showing up on culture?
You want me to step forward on that one? Okay.
Talk about CF and I'll come with.
You bet. Yeah, in CF, let me start by saying in a lot of cases, and I'll see whether McGee agrees with this, but in a lot of cases, we have done so much work in both the clinical and the basic research realms for CF that sometimes what we've found in CF just sort of boilerplate applies to other chronic lung infections. And in a lot of cases, it's not actually appropriate. So in many cases, we're still just learning how these findings apply to other diseases. And we really need to figure those things out in a more precise way. In CF, sorry, now that I said that, I forgot the question. You were asking about, to talk about the difference between detection and treatment. So I think I'm going to take two concepts there. One, that detection of an organism doesn't necessarily mean that we need to get rid of it or try to get rid of it. There are only a couple of cases, really it's mostly Pseudomonas aeruginosa in CF where we treat that bug when we detect it. And it's not because we've shown that when you treat it and get rid of it, because we know we can get rid of it in some people. It's not that we've shown that when you get rid of it, people do better. We actually don't know that yet. We are still just at the point where we figured out, we know how to get rid of it in at least some people, but we don't know that they're going to be healthier as a result. And so we do it at least because we hope they're going to be better, but also because these are antibiotic resistant organisms. And so when people have an increase in symptoms, when they get sick, and we need to treat them with antibiotics because of clinical changes, because they're sick, we have more choices if they don't have these resistant bugs. We can choose antibiotics that are less toxic, that are easier to take, that are easier on the body. So it increases our choices. We also hope that it stands people in better stead, they're better in the long term. So that's one of the reasons why we don't treat all bugs on detection. And we do treat some, mostly just because we want to make our therapeutic choices a little bit more open. Number two, we need to make sure that when people have the bug, that it stays there, because remember, almost all of these bugs are environmental organisms. So we're inhaling them. We might detect them on a culture one day because it happened to be in the throat, or somebody coughed it up, they inhaled it and they coughed it up, and it might not be there the next time. And some of these bugs, like Staphylococcus, for example, have a pretty good rate of just disappearing. So we need to make sure that it's really there, look at it over time, and make sure that it's persistent before we even think about whether it's going to be a problem, which is not a given either. In some cases, people can be chronically culture positive. I'm not even going to use the word infected because it has an implication. They can be culture positive for some organisms and be clinically okay. And none of us want to throw antibiotics at those bugs just because we see them if people are doing clinically okay. And for some of these bugs, for example, Haemophilus, there's not a lot of evidence that, throwing antibiotics at it, even if it's there, is going to make anybody better. Same for Staphylococcus. There's not a lot of evidence that if we chronically suppress Staphylococcus, that people are going to be clinically better. There's a little, but not much. So we generally just watch them. The exception here, again, is non-tuberculous mycobacteria. We're not really an exception, but it's kind of an outlier in that we know that the relationship with disease is tighter than for many other bugs. Some people will chronically have these bacteria in their cultures and never develop disease according to, symptoms. And some people will go on to get much sicker. And we will monitor people who have these positive cultures using imaging, usually CAT scans, lung function, and watching their symptoms. And when they reach a certain threshold, that is, their CAT scans have changed, their lung function is decreasing, they're getting sicker and needing antibiotics more often, they feel terrible, then we'll make the decision to treat, because we actually separate out two states: chronically culture positive for these bugs on the one hand, and number two, disease due to these bugs. So we have NTM in colonization or infection, whatever you want to call it, and then we have NTM disease, and they're not always the same thing. So we want to make a choice only when people get sick.
Excellent.
I was going to stop there.
And part of that is also weighing in the risks and side effects of the antibiotics. The reason non-tuberculous mycobacteria we're very, very careful to make sure that we're going to help the patient by treating them, is these antibiotics have a lot of side effects, and you have to treat for a long time, months and months. So the decision to treat that, I think, has to be carefully considered.
I just thought of one more thing to add to that. Another consequence of antibiotics. We know that people who have had more antibiotics in their lifetime in all these diseases tend to be the ones who have the weird bugs, and they tend to be sicker. We don't know if they're sicker because we gave them antibiotics or if they got more antibiotics because they were sicker to start with. But it is possible that the more antibiotics we use, the more we're going to kill the less bad ones and select for the particularly bad ones. So we want to be really, really careful with these drugs. We know that they have short-term benefits, but we're not totally sure, not just even talking about the toxicities that these drugs can have to the body. We also worry that we're having off-target effects on bugs that actually we want to stick around in the lungs, but also in the gut. I mean, we want to make sure that we're not just selecting out bad bugs that might actually put somebody in a worse place.
Absolutely. Thank you so much. So talking about antibiotics, we have sets of questions that we are going to move forward to. So Siri, please go ahead and ask your next question.
If you could expand upon why those with CF, and I'm assuming PCD, but you'll inform me, are likely to have a higher risk of cross-infection, and why is it more dangerous for these specific disease groups if somebody's culturing something? Why is there a higher risk of cross-infection? And I guess a little tag on to that, in light of what we've learned through COVID, is there a change just knowing the impact of a mask, for example, whether that could shift, whether people within the CF community or PCD community could come together?
Well, I can give you a little historical background on that, because I think things grew over time. But there was a day when we had, CF Family Day, and all the families got together and they learned a lot, and it was great for people to see other people who were dealing with the same chronic disease. And that all was shut down when there was an outbreak of Burkholderia. It wasn't Pseudomonas, it was Burkholderia cepacia, that was associated with a bad outcome. It was not just the infection in the airways, but there was what was called sebaceous syndrome, where people got acutely ill and in a short period of time may die. So that was the big wake up. We need to keep CF patients, and it was in a couple of centers in North America that the outbreak occurred, and then everybody just shut down any exposure of CF patients to other CF patients. And we developed the guidelines that we have now. But the Pseudomonas resistant organisms, Pseudomonas that was resistant to multiple antibiotics, was another one that people started paying attention to, that they wanted to prevent patients from getting that. So it kind of spread to, we need to be careful about multi-resistant organisms. And then it was just, we'll just do full contact for everybody. So it went through stages historically to get to where we are right now, where CF patients are not, we discourage any interaction of CF patients with other CF patients. And we wear, the patients wear masks, the doctors wear gowns and gloves, the clinicians, and when they come to clinic, we like to have them go directly into the room and not sit in a waiting room where they may be around other people, and lots of measures were instituted. Is all of that necessary? I don't think anybody wants to test that. We have it now, and the question's going to come up, I think, at some point with the modulators, can we relax some of this? PCD is on the other end of the spectrum. We haven't had a Burkholderia cepacia event. We haven't had something to say you absolutely cannot be around another patient who has PCD. But we did hear at the meeting that patients who go to a pulmonary clinic that sees CF patients and PCD patients in the same clinic, that some of a relatively high percentage of those patients had multi-resistant Pseudomonas that it looks like they acquired in that clinic. So maybe we should restrict at the same level, but we haven't, they're not guidelines yet. I think there will be a lot of discussions coming about that for how PCD should be controlled.
Excellent. Dr. Hoffman, do you have anything to add?
Of course, I have very, very little, not much. The only concept I'd add is that that people with both of these diseases have a tendency to get these bugs, and that's one of the reasons we feel that transfer and Siri, you asked why people with these diseases are more likely to transfer them. It's not that it has to do with susceptibility to being infected with these bugs, because we're all inhaling them all of the time. And so that said, there are differences between what people with CF and people with PCD tend to be susceptible to. It's a little harder to get some bugs, it seems. It happens later. And so we don't really understand why, at the end of the day. So there are certain bugs that really particularly like the CF airway compared to the PCD airway. We just know that people tend to have a more difficult time clearing these bugs, and therefore they're at higher risk of becoming chronically infected with them. And that's why we want to protect them. And they just happen to be specific bugs that particularly like one airway versus another.
Excellent. Thank you. So Michele, would you like to ask your next question?
Yeah, just looking at other microorganisms, not necessarily bacteria and viruses, fungal infections in these two disorders. We know that they happen. What type of fungal infections are they difficult to treat in cystic fibrosis and PCD more so than in other airway infections? Open
Well,
floor.
I think we do things that make fungal agents happy. we use a lot of antibiotics, so we knock out the healthy bacteria as well as the pathogenic bacteria. And then a lot of these patients get put on steroids, not because there's an inflammatory component, and people think, well, we'll help them by putting on inhaled steroids or a burst of prednisone or something like that. And the combination of corticosteroids and antibiotics can make a really ripe environment for fungal agents. So I think we have to be careful about our therapies to prevent the acquisition of fungal infections. But you're right, they can occur. And the one that I went in my CF days was the one that would cause more of an acute problem was allergic bronchopulmonary aspergillosis, but it was aspergillus that would get into the airways and cause a allergic reaction. So they would have like a severe asthma. They'd get thick mucus and bronchospasm and big decline in lung function and elevated IgE, which is a response to an allergy. So that's the one that we saw in CF a lot. I have not seen that in PCD for whatever reason. And then there are other fungal agents that we're breathing in all the time. And if your airway just happens to be ripe for it because you've been on antibiotics and steroids for a while, you might get a fungal infection.
And to our last point, can those infections be transferred between patients?
I don't think I think those are acquired from the environment. What do you think, Luke? I don't think that.
Yeah, we generally consider those to be environmental and not transmittable. We worry about fungal infections a lot more in people with impaired immune systems, immunosuppressed, and we don't consider them transferable even between those patients. But we're in a lot of cases we haven't done the research to really know. Of course, I totally agree with McGee. I want to point out that just underscore something that she said, which is that ABPA, allergic bronchopulmonary aspergillosis, is not an infection. In fact, you don't even have to detect aspergillus in somebody's secretions for them to be diagnosed with it, which is because we're inhaling it all the time. People are exposed to these fungi all the time. And the problem with defining fungal infection in these cases is that the way that we diagnose infections and look for them is imperfect. We're having people cough up sputum, hocking up a loogie, or taking a swab. And we all have yeast and fungi in our mouths and in our sinuses. They're in part of our normal flora. And when we're giving people antibiotics, as McGee said, yeah, the fungi can kind of go crazy, and it may or may not cause symptoms. And most of us, it doesn't, but it can in all kinds of places, in the skin, in other cavities in the body, in the lungs for sure. But the other possibility is that we've suppressed the bacteria enough that the fungi can now grow in the laboratory. So we may be detecting them more often in these samples, and that doesn't mean they're causing a problem. And I think one of the most telling pieces of evidence about how, pieces of information, I should say, about how bad these fungi are is that when people look at relationships between having fungi detected in their respiratory samples and clinical outcomes, the data are kind of all over the place. There are some studies that have found maybe a relationship between having aspergillus and having worse lung function, unless you exclude the people with this allergic problem. Then there are all these yeasts like Candida that live in our mouth. Some of them have found a relationship between having Candida and doing a little bit worse, having more exacerbations, but then other studies do not find that. And so it's not clear that having them is bad for you universally. That said, I think many of us in the peds and adult pulmonary world have had CF patients who just didn't seem to get better with antibiotics, and we give them an antifungal and they get better. So I don't feel like it's impossible for fungi to be contributing, but I don't think it's common based on the little that I've seen. And that last part, by the way, It's my opinion, editorialized. I think that's controversial, but I'll leave it there.
And I love this because this is the point of a roundtable, but I will say have the detection of it, of ABPA specifically, advanced, because for my daughter, and as an example, she had rapidly declining lung function, put in the hospital. They thought it was an exacerbation of her existing, pathogens. 2 weeks of IV antibiotics, lung function continues to decline. And it was through bronchoscopy that they ended up deciding, based on the eosinophils, I suppose, or you'll clarify, that it was ABPA, and indeed she did respond. So I haven't, knock wood, that hasn't been an issue. So in terms of diagnosis, has it changed? I mean, is it just clinical symptoms and then, is it bronchoscopy? How do you know?
We usually diagnose with a set. We actually have, again, clinical criteria. With bronchoscopy, it can be helpful to exclude some things, but also you can look for these cells that kind of indicate allergy. It's helpful to see those. But blood tests are often enough together with symptoms. And we do have some guidelines for diagnosis, and those guidelines have evolved a little bit. We no longer, it used to be that the guidelines said you have to detect Aspergillus to diagnose it, or at least we'd like that. It's one of the criteria. That criterion is no longer on there, so you don't have to detect it. So they've evolved a little bit. But what I think may have happened is that people know about it a lot more. It's possible that with the more use of antibiotics, it became more common. And I don't know that's true. And so we may have just gotten better at suspecting it and looking for it more often. But we mostly just have clinical suspicion, maybe some, again, some imaging stuff, mostly blood tests. That's probably the most useful diagnostic tool, is looking for these antibodies to Aspergillus that signify allergy. And I think people have a lower threshold for looking now. That is, they look more often than they used to because we became so much more aware of it. I don't know. I think I don't see a lot of PCD patients, but when I do, I have looked for it and never seen it. And I was actually relieved to hear McGee say that it's really, really rare. She hasn't seen it either.
Amazing. Thank you so much. I would
I
like
just have to say, haven't seen it in children. It is a bigger problem in adults with PCD.
Thank you. I'm learning a lot at this webinar.
Yeah, we have to clarify that for sure. But I would like to take some time and move forward to the audience questions. We have a bunch, so I would like to go through it together. And if we can, it's okay. We have other sets of questions as well. So the first question I would like to ask is there any information on CRPA in PCD? Is this strain any more or less problematic than the other strains?
Carbapenem-resistant Pseudomonas.
Yes, sorry. I would have tried, but
I don't have it. I don't know anything specific about that in PCD. It's probably just a organism that's been selected out from being exposed from the patient being exposed to those antibiotics before, but I don't know if that's specifically with PCD.
got it. So we'll go to the next question. So what is the relationship of inhaled, wow, these are hard words.
Corticosteroids.
Thank you. Corticosteroids and pneumonia risk. What happens if the patient has an asthma overlay and their primary disease?
If they have asthma, they need to be on inhaled corticosteroids. But if they do not have asthma, you're not seeing a benefit of the inhaled corticosteroids. You're introducing a risk factor. So if you have asthma, by all means, stay on your inhaled corticosteroids.
Dr. Hoffman?
Yeah, I'll just add to that regarding the first question. In people with asthma, it used to be thought that taking inhaled steroids might increase your risk of getting pneumonia. The problem is people with asthma are frequently, who are poorly treated or inadequately treated, have a high risk of being diagnosed with with pneumonia, because pneumonia can be diagnosed with a chest x-ray, and sometimes just poorly treated asthma will look like pneumonia. So we had a chicken egg problem, whether people who with asthma on steroids tended to have more pneumonia, or whether people with asthma just had more pneumonia and they were mostly getting steroids, whether the steroids had no role in that. And the best studies to date that I know of kind of suggested that the steroids were not the cause. They were just a marker of people with severe asthma, more severe asthma. So we don't think that inhaled steroids put you at risk of pneumonia, whether it's in asthma or any other airway diseases like the ones we're talking about today. For people with asthma, we really feel that the benefits greatly outweigh any potential risks, and we don't know of major risks other than increasing your fungal load, as Miggy just mentioned.
Excellent. Thank you so much. We'll go to the next question. Is there any benefit to avoiding environmental bacteria? Is it even possible? No, right? Masks are the only option, or is there any more? Would you able to say anything on that?
It's a really good question, and actually, you could dismiss it out of hand, but actually, people have asked this for a long time. Part of the problem is that for Pseudomonas, for example, we don't know where people get it from. We know where you can find it in the environment, but we can't find a good relationship between the ones that are infecting people and where we find it and the ones that we find out in the world. So we don't know where they get it from necessarily, and that makes it hard to know whether avoiding certain, what to avoid. In addition, there have been some really good studies that have looked at predictors of whether people are going to get Pseudomonas in terms of where they've gone and what they've done. We used to ask people not to sit in hot tubs, for example, or to avoid swimming pools. And there have been many studies that have failed to find a relationship between exposure to either of these things and getting Pseudomonas. So now we're not totally sure that needs to happen. People will vary. Your treating doctors will vary in terms of their recommendations, but we don't have any evidence that changing behaviors, avoiding things other than other people with the same disease with big burdens of bacteria are going to protect you. So yes, I think your instinct was the way that we're starting to lean, Nusrat. We don't think you can avoid them. All we can do, just as Miggy said at the beginning, is encourage people to increase their clearance and so they can clear things out after they inhale them as much as possible to prevent them from setting up shop, and establishing an infection.
Amazing. Thank you so much.
I feel like Miggy probably has something. She knows a lot more than I do, so she probably has something to add to that.
Well, there are some bacteria in the soil that if some people got some of those infections, that you might tell them that they might think of a different job than their job digging in a garden all day long. They might take up a different sort of occupation or something, but that's the only thing I could come up with in answer to that question.
So the only thing I want to just point out is that there are people in the NTM community who are told or tell each other not to take showers because the NTM is coming from the shower head and it's aerosolized. They can take baths, but not showers. And there's a lot of people that kind of do that, and they really change their life to try to avoid these environmental pathogens. And is there really any evidence to suggest that that's helpful for like NTM?
I'm going to have to say that I don't know of any. I've talked to some experts, Jerry Nick, for example, about this, and they don't feel comfortable saying that they know. Part of the problem is that these are hard studies to do to figure out where people get these bugs, especially with NTM, because often there's a long duration between exposure and detection. And so nobody really knows where they come from, although there's some evidence, controversial again, that people can transmit it from person to person. It's hard. And I can't argue with anybody's advice in this particular case. I do want to bring up one recommendation that's often made, however, that I forgot for people with impaired clearance, and that's avoiding situations where there are going to be antibiotic resistant bacteria in the workplace, like or at least protecting yourself, becoming a nurse, becoming a doctor, being around people who are going to have these kinds of respiratory infections. We never stand in, or we try not to stand in the way of people's dreams, but we do like for people to protect themselves when they do.
Amazing. Dr. Lee, do you have anything to add?
No, go ahead.
Awesome. So we're just going to move forward to the next set of questions. We do have 10 minutes to the webinar. So Siri, why don't you go ahead and ask your question?
Reference has been made to Burkholderia cepacia as like the dreaded, I mean, and I can say in the CF community, that is the dreaded pathogen. Can you explain why it is such a dangerous pathogen, and also the different strains, and whether, you know, is one cepacia just like the other cepacia, or are there different variations, some being more problematic for people?
Go ahead, Luke. That's more your type.
Okay. I want to preface this by saying there are experts in Burkholderia in this country, in CF, and they certainly know a lot more than I do. And what I'm going to tell you is basically parroting what I've heard from them. Things have changed to a certain extent. As McGee was pointing out, a number of years ago, there were a number of outbreaks with what we called epidemic strains of Burkholderia cepacia. At that point, we did not understand that Burkholderia cepacia is actually probably more, a couple of dozen, maybe 20 or more actual species. They're not all the same. And so sometimes we will detect a Burkholderia that is not the same species as the one that caused the problems. And they don't have the same implications. They don't have the same clinical impact. That's number one. So now we actually are able to resolve, we have much better resolution when we detect these organisms, and we can figure out which species are they. Of them, only a couple are really associated with worse disease in CF, and we really don't see them often in PCD. In fact, I never have. Michele, I defer to you about whether they're seen in adults or not.
They are.
Okay, well, there we go. But there are really only a couple of species that seem to be associated with worse disease in CF. And of those, one of them was responsible, as far as we know, for these epidemics. And those epidemics have become much, much rarer. We rarely ever see cepacia syndrome. And there are a lot of theories about why that became less common. That mostly happened in the 90s, the 80s and the 90s. And then we started to see fewer of them. It may have been that we're preventing interpatient transmission. It may have been there was actually a change in the environmental organisms that, and for some reason, and they got replaced by ones that are less likely to cause this clinical scenario. We don't really know. It could be that we're treating them better, but we haven't really changed our clinical protocols. We still don't universally try to eradicate these bugs when we detect them. Some people do, most people do not. There's no real consensus on whether to do that. So it's not because we're doing a better job as doctors. Something has changed either in the bugs or just, you know, preventing interpatient transmission seems to have done that. It does happen. We occasionally there have been cases of what's called cepacia syndrome, but that's usually isolated cases, one patient, not a big outbreak. It's we really don't see that very often anymore.
Excellent.
Now, I should point out, I actually was not even in this field when those big outbreaks were at their height. I started in this field in the late 90s, early 2000s, and they were already sort of on their way out. So McGee has much better historical perspective here.
Yeah, we lived them. It was awful. But you're right. There are different species of Burkholderia gladioli. Probably rarely is a major problem, but sometimes people have exacerbations and you treat that and can eradicate it. But I would not treat, personally, I would not treat unless there was an exacerbation or reason to treat. And we didn't really get into this at the beginning, but I think we get cultures not to say if we find something, we've got to treat it. The reason we get cultures is so the next time you get sick, if you get sick in the next 3 months before your next visit, we've got a basis on which to direct therapies. It's not a guarantee that whatever organism is making you flare up is the one that was recovered in that culture, but it certainly gives a starting point on where to target your efforts.
Excellent. Thank you so much. Michelle, please go ahead and ask your last question of the webinar.
So yeah, I think this is actually a Siri question. We just had a little conversation about short on time. There's one thing we really wanted to get to, probably more relevant in CF, but I'll go ahead and ask it. And that has to do with phage therapy, which I think is very exciting for a lot of patients. And what do you see on the horizon for these disorders and phage therapy?
I'll happily step forward on that one too. There is a lot of interest in developing phage for treatment in CF in particular. Phage has been used in some other infections, like systemic infections in the blood, wound infections for a while. These are different from standard antibiotics because they really are antibiotics in that, one, they're viruses, they're naturally occurring. They're not, for the most part, they're naturally occurring, and although sometimes they're modified by the companies that are developing them or the researchers. Unlike almost all antibiotics, they target one particular bug, whereas all the other antibiotics we use generally kill or suppress a lot of different bugs. And so at this point in history, and by the way, phage therapies are nearly almost always administered with antibiotics as well. So we don't know that phages are going to change the game. It could be that the phages that people are developing for one bug are going to make people better and not have as many off-target effects on the other bugs. Or it may be that actually antibiotics were helping people by suppressing lots of bugs, not just the one we're targeting. And therefore, a phage isn't going to work as well. But we're excited because this is the first time we're going to be able to test it. There have been some success stories with phage for people who were really sick, where phages were administered in sort of one-off compassionate use N of one trials, we call them, one person, where people really stabilized, and those tend to get published. We don't tend to see the ones that don't go well. So you can find some of these trials in the literature. And I think for example, as a CF microbiologist and pulmonologist, I'm excited about what we're going to find out in the potential for phage therapy, both as a treatment for an acute exacerbation and also as a chronic maintenance therapy that has fewer toxic side effects. I think that we all have a lot of questions about how much it's going to help, how durable any effect will be, because these are naturally occurring viruses that actually you can find them all around us. Anywhere there are bacteria, there are phage. And so it's possible that that resistance will come up as it does in nature quickly, but it's possible not. These have been carefully studied before they even put them into people. There's good evidence that they're safe at this point, and that's good. So we're at a point in history where we've established they're safe. They might work. There are good reasons to use them. So we stop using toxic antibiotics. I think it's a great idea, but I think a lot of us are holding our breath just to see how this goes, That's my view.
Amazing. Dr. Lee, do you have any feedback or update? You have any input on that?
Well, only just real quick before getting on, I just looked to see what was new published in 2024 in CF and non-CF bronchiectasis. Bacteriophages is one, so that's a hot area. Another new agent is Diracal, which is for gram-negative agents. That's something new and coming. And then omadacycline for Mycobacteria abscessus. So the point is, you don't need to know all these agents, but the point is there are people looking for new therapies for these organisms that can help. And we all recognize that drug resistance is a problem. We got to come up with some new things.
Amazing. Thank you so much. I would like to ask Dr. Lee and Dr. Hoffman, thank you so much for joining us. Do you have any last feedback on this topic and this webinar? anything you would like to add and let the audience know?
I'll
And-
just say thank you for inviting me, and I'm really encouraged by the enthusiasm and the questions. There are a lot of people still, a lot of people working on these infections. And our goal is always to make what we work on responsive to and important to the people who have these illnesses. And so I welcome feedback and questions like this.
And I just say there are no quick, easy answers to these issues. And really, I hope all of you have a good physician who's going to think about the pros and cons for treating in every situation, because it's not just you've got this organism, so we're going to treat you with this. It's not a simple thought.
That's a perfect way of sum up this webinar and this topic. I would like to say thank you so much to both of you and to Michele and Siri for making this happen. To all the audience, thank you for joining us today, and thank you for being part of the first lung disease webinar for the year. And this live will be active in our website within this week, hopefully, but it will be in YouTube soon. So thank you so much. I will email everything, the link to this website and the link to the webinar whenever it's active to all of you. So thank you again very much. I really appreciate it. Thank you for educating me. Thank you for educating all of us. I really appreciate it and hope to work with you both soon.
Thank you.
Thank you. I learned a lot too.
Awesome.
Thank you,
Take care
everybody.
now. Bye-bye.